สวัสดีนักศึกษาทุกคนนะครับ Hi everyone, my name is Dr. Korapat Mayurasakon. I work at Department of Research and Development, Sirat Hospital, Mahidol University. If you have any question, please email me on the email below on these slides. And in this session, I would like to talk about experimental study designs. Please follow me. So after this session, you should be able to learn three separate things. So first, describe experimental study design and describe factors to be considered when carrying out experimental studies. And lastly, explain how to minimize research bias so that you can produce a good research in proper way. So let's start with the first topics, experimental design. So in general, I think everyone has experience more or less on research designs. On the left side, you can see the type of research design that we call the observational designs. So basic is that observational, you don't do anything with the participants or animal. You just observe the activity that happen in population.In this case, population of you may be human or may be animal or maybe the cells or equipment. And on the right side that we talk about today is called the experimental designs. So basically there are generally the two studies on the left side, observational studies and experimental trial on the right side. Sometimes we call the interventional study.And the classical application of experimental design is the studies in human that commonly known as randomized control trial that is very popular in medical field because people think that it's really standard and the result of this trial is reliable and it's useful to make use in clinical research and make use of clinical research to daily life, hospital care. And less standards we call the quasi-experimental or field trial or community trial. And if you can look back on the left side, there would be a population-based study of the huge population that sometimes you can see like a health survey, national health survey that happened in Thailand and also they happen in many studies designed like a cohort study.So in terms of population-based and individual-based has very similar ways of research methodology. And if you look down on the lower of the slides, you can have analytical observational studies called the cross-sectional study and case control studies and the cohort studies. Before I begin, I want to make a few clarifications on this slide first. In general, we divide the scientific evidence into two parts. On the left side, it's more scientific proven evidence, and on the right side that you can see from YouTube video or personal information or any kind of news or any social medias. We all agree to put it on non-scientific evidence, even though it has a lot of people show the evidence in the same way, but then in terms of research, we still put them on the right side, like non-scientific evidence. But on the left side, first, this hierarchy of evidence is a general guideline, not the absolute rule, and there is no one universal agree.upon hierarchy, but it's widely agreed that the order presented here does rank the study design themselves in order to robustness. Let me give you example on the popular case COVID-19. Sometimes you get the case reports from COVID-19 or disease at the moment. You don't have randomized control trial. So in that case, it doesn't mean that it's the weakest scientific evidence, but it's the evidence that you have in hand at this time. So sometimes case report is really important. Maybe not as good as the meta-analysis, but sometimes it's the only things valuable at that time. And sometimes, for example, if you do a study on common like food diet, general behavioral changes. You don't need to study from animal trial. You can jump into cohort studies, case control studies, cross-sectional study, or randomized control trial. You don't need to run by this order. So again, we're talking about difference between observational and experimental studies. Think about it. Do you think what is the difference between of the two? So first, observational study and experimental studies. So the difference is, like I said, observation, you observe what happened to participant, what happened to animal, what happened to population, with no interference by the investigator or researchers. You just observe the way that they behave, like you observe their prevalence of their obesity, prevalence of diabetes, prevalence of cardiovascular disease, or any kind of prevalence of something that you interest. But on the other hand, if you study on experimental studies, you study on cause and effect relationship. What does that mean, cause and effect relationship? You compare between the group as well, and you maintain control over all affected factors. Let me clarify in these details. In experimental design, for example, you want to study something. For example, you want to study new medication against COVID-19, and you want to see the improvement of the lung function, improvement of the blood parameter. So in this case, the cause is the disease and medication that you use with patient, and the effect is the health outcome. So, but in order to compare between the placebo control and the medication that you developed, you need to have compare groups. And in order to see the result directly from your intervention, you need to have control parameters. Control parameters mean that sometimes you need to control because you know that your intervention may be affected by exercise, may be affected by diet, may be affected by sleep, or affected by anything. In that case, you need to control other kind of factors that can have direct or indirect effect of the outcome. So this is called the randomized control trial. And when you want to study something, and you want to study the outcome of that something, sometimes something that we talk about is independent variables, or in the recent days we call the predictive variable, because you know before that it may have the effect on the outcome. And the outcome in this case we call dependent variable. So again, experimental study design, the concept is to determine the cause of something by isolating the hypothesized causes and comparing the control result. This is the something that we call the actual proof of causation. Let me explain it. Let me give you an example of this day people talking about obesity, right? And we want to try a lot of diet protocol to reduce your body weight. Let's say, for example, ketogenic diet. People know that ketogenic diet can lose weight in certain way under certain metabolism, and then at the end you can lose body weight. Ketogenic diet is something you change by reducing the carbohydrate diet and increase protein and fat diet. So this is the actual proof that can cause the losing weight. But think about it. Losing weight is not something just for the diet. Some people can lose weight because of they control their exercise, they improve their exercise, they do something else without changing their diet. So therefore, sometimes the ketogenic diet can cause the effect that you like, but the effect that you like can cause from something else as well. And in order to make proof of this cause and effect, you need to control exercise, so that everyone has the same exercise activity. And sometimes people see that not only the exercise, but the age of participants also affects the outcome of the body weight. For example, if you are the elderly population, the potential to lose weight is less than the young generation, because young generation has time and probably they have more power to do some more exercise. So in that case, the black arrows meaning that you need to control other kind of factor that can affect your outcome, so that you can see only the clear outcome from your cause, which actually in this case is ketogenic diet, and effect is the body weight. This is another example of experimental design. Let's close to your field. This is the picture of the study recently published about the shoe. So their research is something that they want to study that what type of shoes. So in this case, this arrow here is called the midsole. So, and on the top here is called the upper top structure of the shoes. And the researchers try to see what kind of design, like what kind of midsole materials and upper structure of the shoes that can help to accommodate the runner, to make the runner run faster. Think about it. So in this case, the cause of the experimental design is the design, the different concept of the shoe, both changing the midsole materials and also changing the structure of the upper part of the shoe, and study the outcome. The outcome probably may be the time to run at 10 kilometers, or maybe the comfortness of the runner, or maybe the injury of the runner after wearing different type of the shoes. And how about quasi-experimental design? So quasi by itself is something less standard than experimental designs, but it also still examines cause and effect relationship, but sometimes you unable to control any control variable, and samples are not like randomizely selected, and all variable cannot be controlled. For example, if you do a study in village, for example, you cannot control everyone in the village. You cannot ask everyone not to talk with each other. Some of the participants may have a chance to chit-chat with other participants, and chit-chat make them able to change the outcome of the studies. So therefore, some of the studies, experimental study designs, they cannot control everything, even though that they know that it matters to the outcome. So in order to reduce or minimize the bias, some of the studies in quasi-experiment, it needs more subjects or more kind of control in different aspects. So let's think about the plus side of experimental designs. So the plus side of experimental design is that if you want to study something never known before, never studied before, you can just read the article or case control or any kind of publication. Sometimes you need to generate very specifics to your population, to your culture, to your country. For example, Thai people, they eat rice, but in US population, they probably eat more bread than rice, for example. So in order to study rice, then you probably want to generate an experimental design that tailor-made to your interest and your population. So again, it's able to make the causal inference. You can control confounding factor because you start from the beginning of the trial. And also you can do a randomization at the beginning. And this helps to answer very specific question. In terms of experimental design, basically we are taught that we have to have maybe 1 or 2 objectives in the studies. We can have 10 questions in the study because experimental design is very specific until you need to answer very specific question, basically less than 1 or 2 questions at a time. And sometimes you want to test novel therapy, or people say why you need to do a more experimental design since there are a lot of designs before to prove this medication. Sometimes you do a study because you want to confirm with the previous outcome before, or you doubt with the outcome previously before, you want to do another confirming test in your studies, it's also possible to do experimental design. But the problem is the experimental design is not that easy. People usually have some dropout rate especially when you do a long-term experimental design, like 6-month trial in human, or even animal. You do a long-term trial. Animal drop out, not just drop out, maybe pass away or die because of your experimental. And ethical issues and external validity is issues, meaning that sometimes when you do experimental design, people can skip out from the study easily because they feel uncomfortable to do a long-term design. And 3 M's is always has to be considered. First is money, because experimental design use a lot of money. Man use a lot of people, subjects, and your staff to run a trial. And more importantly, it's a time-consuming experiment. You cannot just run maybe for 1 or 2 days, it depends. But basically, some of the experimental you have to run for 5 or 10 years, so it consumes a lot of time. And drawback is that, another drawback is the prior knowledge is required for sample size calculation. So sometimes you have no clue before any trial. You need at least something, beginning of the trial so that you can start a protocol or running the protocol. And in fact, it is not the actual explanation. Like I say, let me clarify this word. In experimental design, you study cause and effects, but like I said, there's many causes that can cause the same effects. So if you want to prove it, you need to do some more kind of experimental to answer this question. So it's not actual explanation. It just study the actual proof of causation, specific causation. And extraneous variable or other kind of factors that can affect the outcome sometimes cannot control. If you can control, it's called extraneous variable. And if you cannot control, sometimes people call confounding variables or confounding factors. Okay, let me review research that you learned in this class before. So in research, we talk about systematically obtain valid answer to a specific question. In terms of research design, we basically try to answer only a few questions. We don't want to answer many questions because it will take time and consuming a lot of resources. And in research, in experimental design, you want to answer a new interpretation of the data or text, or maybe pose new questions for further research to explore. And a good research is something you ask important questions and answer it validly or reliably. So it's someone saying it depends upon how well an investigator formulate the research question based on problem face-to-face in daily life basis and in clinical practice. Sometimes we call the routine to research. So let's practice with this again. With my example, I already given you on the agenda. So let's review it. So how to formulate a clear and a specific research, we're using the PICO. So P stands for population, participants, or even cells or animal. And I call intervention, and C is control, and O is the outcome. Okay, and everyone please take time to read experimental study example here. So I have 3 example of article published recently before. I want every one of you to pick one of these and try to read within 10 minutes and write it down and try to describe in terms of PICO. Okay, so now we go into the detail. So P stand for the sampling group to studies. We're talking about the sample that everyone should be considered it as a representative of the population. For example, if you want to study diabetes population, you need to name and clarify it. What type of diabetes you interest? Like for example, you interest in the elderly population. So therefore, in this selection of research protocol, you need to be more specific as possible so that the research outcome can apply directly to your population of your interest. And relevance to the studies is also important. If you do study that not relevant to your interest, then you deviate from your research interest. And the numbers have to be calculated enough to see the outcomes. And in this case, I would like you to consult a statistician so that you can make sure that you can get a good numbers before you study. Too much numbers, it's make you losing your time and losing your money grant. But too few, then it's likely a risk for not enough participant in your study. And then we are talking about eligibility criteria. So there's two, which the first one is inclusion criteria and the second one is exclusion criteria. For inclusion criteria, you select something in your study. For example, if you want to study the infection COVID-19 and its effects mostly in the elderly population, right? So the inclusion criteria probably would be the age of your population and maybe including the severity of the disease before or comorbidity disease in the inclusion criteria. And for exclusion, some of you do similar mistakes. For example, if you want to study COVID within the elderly population, you put in the inclusion criteria. You don't need to put in exclusion criteria that you don't want someone else without COVID-19 because it's redundant, you already write down in the inclusion criteria, so you don't need to write the same thing in the opposite side in the exclusion criteria. And in this slide, I would like to give you the example of the model that we call diabetic mouse model as compared to the first column here, which is human. We all know that human has type 1 diabetic, have type 2 diabetes. Also, someone probably has gestational diabetes, and lastly, someone may probably have a defect in single gene that we call the MODY, maturity onset of diabetes of the new young. So when you study the diabetes, you need to be very specific what type of population you want to apply to, and someone might interest in mouse models that sometimes you can answer something that cannot be answered in human, like you want to study a brain tissue or liver tissue. Then in that case, you want to move to animal studies or cell studies. And in the world, there is a lot of model that can similar apply back to human. Like for example, you want to study monogenic disorder that can be applied to MODY in human. Or something else like C57BL6 mice, that's generally just normal animal with some defects. This slide I want to show you that the animals have genetically modified, have a leptin resistance or lack of leptins, and generally animal, for example, OB mice, they are obese even though they don't eat that much. They're obese by nature and they have insulin resistance. In this type of the model, if you're interested, you can study the effects of the outcome after you change your diet or effect of medication in this animal as comparing to the wild type glutamate, that you can see that they probably eat very closely, but the size of the body is different. This is the same thing. At the same age, the size of the body weight is so much different, as you can see by this picture here. And this is something different. I usually, before I study the mouse model that's similar to Asian population, we all know that in Asia, right? People develop diabetes even though they're not obese that much. As you can imagine, in U.S. population, in Western country, when you get diabetic, basically you correlate, associate with obesity. And obesity in the U.S. or Western country is really huge. The body weight is really huge. But as compared to Thai population or Asian population, you can get diabetics even though you're not that old and even though you're not that obese. So caveolin-1 knockout is one of the representative to study in this human model, because caveolin-1 affects it's a plasma protein that can affect lipid metabolism and glucose metabolism. And when we do a trial in this, we discover that this mouse model has insulin resistant and become diabetics in very early age of the animal. Okay. Now, I want to give you some more of the concept about when you design the types of hypothesis. So back many years ago, I believe that you study and learn about the concept of null hypothesis before. So null hypothesis we call the H0, and alternative hypothesis we call the H1. So H1 means something that you want to study, and null hypothesis is something that you make at the beginning before. Usually the hypothesis in null hypothesis, you will name it like no difference. And alternative, you want to study something new. For example, you want to study a new medication to cure the COVID-19. So the null hypothesis probably would be this medication doesn't work, for example. So let me give you example. Supplements of vitamin C, people think that maybe it's protect against the SARS-CoV-2 or COVID-19. This is just general statements. And alternative hypothesis it would be vitamin C has an effect to protect this disease. That's something like that. Let's talk about the powers and sampling designs. Like we talked before, our topic is supplement of vitamin C to protect against the COVID-19 or disease of our interest. There's many terminology in this slide. So 2x2 table. So the truth in population is the truth in population that whenever we prove it, it's going to be true. Like for example, if we know that vitamin C work against the COVID-19, so this we put them in the truth of population, but it's different from null hypothesis that you can name like no different before. Let's say that the truth is the truth, and when you do a null hypothesis, saying null hypothesis is no association, and when you run a test, run a studies, and the result fail to reject the null hypothesis, meaning that the result come out like no different. This is correct conclusion. But if you run a studies and it turns to be reject null hypothesis, you see the difference in your experiment, even though the truth there is no association. This is called the type 1 or alpha error. Usually alpha you put them in like a 5 or 10. That's why you're familiar with p-value less than 0.05. And in order to fix it, you probably want to do a better sampling technique in population, or you increase number of the population also can help minimize the type 1 error. But the type 2 error or beta error is something that basically it should not happen because it probably caused by something wrong in your study designs or everything else. So for example, the truth in population, even though the null hypothesis you're saying that there's no difference, but the truth actually is exist. You know, the truth is exist, so then you probably want to reject null hypothesis, meaning that the result exists. This correctly conclusion. But if it fall into fail to reject null hypothesis, meaning that no different, then it fall into type 2 or beta error. So I would like you to take some time to review this slide because it probably takes some time to understand. And once you understand, you can create a better research design. Secondly, intervention. So basically, you want to compare between groups, and the factor you have to consider in this case is something about intensity, meaning the dose of the intervention and the repeat dose or any kind of dose that you used in the experiment, and duration and frequency of the treatment, like for example, how many doses you want to use. And there are general guidelines saying that if you want to study something that very serious condition, let's say a deadly condition like COVID-19, if you get disease, then likely chance to have morbidity and mortality is increasingly high, then the effect of the intervention, they want to use the highest dose possible to see the effects, because effectiveness is the primary concern. But if you want to study something very slightly mild condition, like a skin rash or something else that not affect your health that much, so the safety is the issue, is the primary concern. In that case, you want to study by using the lowest dose as possible. And you think about intervention, how to generalize the study after the study finished. That we call, another thing we call the external validity. For example, when we run studies in patients, we control everything in quiet room, control everything, diet, exercise. But in real world, it's very difficult to make implement of this trial because it's difficult to apply to real population. So then you have to think about it too. Let me give you this example. This is a very well-known study published 2002, so many years ago, in New England Journal of Medicine. They want to study comparing between placebo control, comparing between the metformin, the glucose-lowering medication, very popular medication, comparing to lifestyle modification. The results showing that after the following for 3 or 4 years, lifestyle modifications improve the incidence of diabetes far better than metformin medication, better than placebo control. But if we look in the detail of lifestyle modification, we discover that in lifestyle you need to very intense with your exercise, with the diet. If you don't have shoe, then we buy shoe. If you don't have diet, we purchase the diet for you, for example. So this is a good example showing that lifestyle can have a better effect on medication, but in the real world, it's probably difficult to apply directly to everyone because everyone has a different lifestyle. And this is the example of my protocol previously published before, showing that we compare between groups of the animal to see the effect of calorie restriction, meaning that the animal has to eat less than its usual diet, and we want to see the outcome in cardiometabolic outcomes in animal, as compare animal with the wild type animal, compare with the caveolin one knockout animal with a different type of the diet. Let me give you the example that when we run a test, we have day -5, which is maybe called the watch out period, because we want to standardize the diets that every animal have before we start on the day 0, and we do a blood test and follow them for a long period of time. And we want to study, anything that we want, like glucose tolerance test, insulin tolerance test. So this is an example that you can copy and make use in your protocol, so that make your IRB teams review board to see clearly understand about your research protocol. And this another thing of experimental we call the diet study design to see the effects on HDL metabolism in people with metabolic syndrome. So again, this is just example showing you that in our protocol we have a screening time. In the screening period we have questionnaires, we have physical activity assessments, we have a lot of criteria, we have a lot of blood tests to collect, and when you start on the day 0 we collect this type of measurements and follow them. So another thing that I like to suggest you is something called the staggering studies. What is that? So sometimes when you do a studies in human, like you limit of the room, you limit of the classroom or anything, you limit of the personnel, you cannot start everything at the same time. So sometimes we do a staggering of the cohort. You can start the first group on the day first, and then you can start the second group another week later, and you can try the third group maybe 2 weeks later. That we call the staggering cohort. So this is an example I did before, like several years ago. So in the first group we run the blood pressure training, we start the diet, we measure the food intake, we measure the blood glucose, insulin and lipid measurements. And the second group of the cohort, we probably have like 10 or 15 animals. We run on 9 days later, and then the last group we run another 9 days later. So the first and the last probably has about 2 or 3 weeks apart. Then another consideration for intervention is something you think about promising doses. You need to decide what dose you want to use, what type of equipment, what type of design you want to use, or sometimes you want to use a single intervention, like the slide I presented you before. You study one medication and comparing between exercise. But if you want to think about some patient, they want to use medication, exercise together. In this case, instead of having placebo control, one medication and one exercise, you can have the first group that combine between medication and exercise. In this case, we call factorial design. And you can have further more complicated intervention. And then C, we talk about the control. You have a control group as compared to intervention. In that case, it will be simply, but you need to start the control intervention at the beginning of the time, and you use the same protocol to follow them so that you don't have any bias comparing between control and intervention. And I will tell you later on how to control the confounding factor in that case. Okay, terminology that we want you to understand. So in the control group, you can have no treatment at all, like no treatment at all. And like for example, when I follow a hypertensive patient, so in no treatment meaning that you don't give them anything. Or sometimes, because participants and your study personnel know that this type of patient do not get anything, they can have any kind of bias in terms of taking care of participants. So sometimes we give them placebo control like a tablet of vitamins, or in terms of surgical procedure experiment. For example, when we do a surgical procedure in patient and you do want to study a new technique in surgeries, sometimes you need to do a surgery like a mock surgery, like you open the wound and close the wound without any kind of further treatment. In that case, we call sham. It's always, many times happen in animal that you want to study surgical procedure in animal, but the wound can affect the outcome of animal. Sometimes you have to have a sham group animal that you open the abdomen of the animal and then you close it so that the experimental group can have a wound closure as same as the placebo animal control. Or sometimes it's illegal to stop medication with patient. Like for example, if you know that conventional medication is to improve the disease is, for example, metformin. You cannot stop metformin because it can affect the outcome. It can affect the safetiness of the patient. So sometimes you need to give conventional medication. We call the active treatment control. And then you need to allow a restriction or something, but in terms of intervention group and control group has to be the same. So this is another study that we designed to study 3 groups. So comparing between of the diet and the outcome is to improvement is the metabolic syndrome. So the first group is we call the yolk ketogenic diet. And the second group, we put the egg yolk out from the diet. So we call the white ketogenic diet. And comparing between the active control is generally it's the losing weight protocol. You know, everyone see the doctor always saying that eat less, so something like that. So we put the eat less scheme in terms of reduced energy intake as a control in this study. And lastly, we're talking about the outcome measurements. So in terms of experimental design, basically we try to measure the primary outcome, maybe 1 or 2 primary outcomes. And you can have secondary outcome. There's outcome that if you can't find the result, that should be fine. The outcome, that's something you don't expect to get the result. You expect only primary outcome. So the most important outcome, you put them in the primary outcome. And something that secondary, you're not sure the outcome will turn out to be true or not true. You put in secondary outcomes. And sometimes you measure the adverse outcome like nausea, vomiting, weight loss, or something else that may be affected by your intervention. I give you example, the single outcome like total death, occurrence of the disease, or in that case of obesity, you measure the body weight, glucose homeostasis, blood pressure, cells, or enzymes, or improvement of your running time. Okay, and other kind of measurements that you have to think about outcome measurements. You have to have clear outcome, appropriate, acceptable definition of the outcome that you want to measure. You can't say something very broadly. In terms of study design, you need to be very specific as possible. And you need to use a standardized measurement tools. Like if you want to study body weight, you need to use the same weight measurement machines, blood pressure measurement machine that has been cited as a standard machine. Another useful thing that I like to discuss today is something about repeated measurements. Any one of you known about this before? So, repeated measurements is useful measurements, statistical analysis. So, sometime in your research, you want to study at the beginning of the test, like time 0, and you compare at the end of the studies. But some experiment, for example, if you want to study the obesity and losing weight from ketogenic diet, you know that over time, not only your intervention, over time, when the time takes place, the time can have an effect on your outcome. So if you study by using the study designs, the measurements we call student t-test, which actually compare between the beginning and the end. It doesn't compare the time in between. And you think at some time, the time in between probably has some effect of the result. Then you probably want to use the repeated measurements. But limitation of the repeated measurement is that every time point need to have a data like blood pressure measurement every time point. If you have some measurement skipping, then it would may be difficult to do repeated measurements unless you have missing data from some subject in the population. this can be possible to run a repeated measurement. But if you're missing a lot of data in many participants in different time point, then maybe you want to go back to use different type of analysis techniques like student t-test. Okay, we go to the last point. The important things when you do a research is the experimental study, but in order to make the research reliable and make sure that the outcome is really result from your intervention, you need to reduce the bias. So some saying that experimental design, you need to neutralize or control the other factors as possible. Like I said before, that's called internal validity factors. When you control things in your control setting, in your room, in your experimental designs, that's how you control inside of your experiment. But once your results, your research is going to apply to general population, you need to think about external validities. Like for example, if you run medication to cure the COVID-19, it can work well inside your studies, but sometimes when you apply it in general population, maybe it's not working by some reasons. In that sense, it's failed in terms of apply to external validity. There's many types of measurements to reduce the bias. The first called randomization, the second allocation concealment, the third is maximize adherence and follow-up, and some kind of minute things that you want to think about it. Let's start with randomization first. Randomization is to prevent researcher, you, clinician and patient from predicting the outcome, thereby influencing the experiment. Let me give you in more detail. Randomization is like you toss a coin to participants, or you do a sequential randomization. So the participants and researchers don't know what group the participants going to go through. And this will help to give all the participants equal chance to be assigned to a given group. Like sometime you know this participant, like maybe you are a friend of this participant, you know each other before, and you know that this medication works, and you want your friend as a participant to get the better drug medication. You know, in that case, then it's not proper research design. So in order to do that, you do a randomization. You probably want to put someone that no participant out from your recruitment process, or you do a full randomization. So everyone, researcher doesn't know participant, participant doesn't know researcher, or participant doesn't know the treatment. Like you blind everything. So sometimes we call double blind or single blind. Double blind meaning that researcher and participant doesn't know anything. A single blind, maybe participant doesn't know alone, but researcher know about intervention they're going to use. Another thing we want to think about is study design, like you want to study animal. The time of the day, for example, as I remember before when I studied long time ago in animal, and in one day you have to do like 20 animal a day. So the first animal, you probably feel not like ready enough to do the first animal. So the first animal result may be not as good as the third or the fourth animal that you run a test. And the last animal you want to run, maybe sometimes you feel tired to run a test with that animal. So then think about this bias that can happen in the animal. So another thing, when you do measurement, for example, in the middle of this slide is a blood measurement, and you want to divide the plasma into 2 tubes. And let me give you an example. If you aliquot the plasma on the yellow color here by aliquot all of them in the first tube, and then you aliquot from the overall, the first tube into the second tube. This is one method. The second method is that you aliquot half and half into different tubes. Believe it or not, both of these methods can have a different outcome. The first one, you aliquot first, has a likely chance to get the equal amount of the biochemical marker that you like, but the second one probably has less chance, probably has a different outcome in terms of measurements, because you aliquot first and you change the tips, you change equipment, and then you put in the second tubes. And another thing to consider about the outcome, it is pictures of the Western blot, showing that some of the Western blot techniques, you have the effect on the first slot of the well that can have a smiley face, and when you measure the intensity of the outcome, they probably affect differently. So think about the outcome and sequential of the sample you want to run. Think about the method you want to run, the test or aliquot of the sample too. Major categories that we call the randomized control designs. This is called single arm trial. You have only one experimental design. One group study before and after test. Or you can have parallel group design. On the right side is called a parallel. You have control, you have intervention group run at the same time. Or sometimes you can have, we call the crossover design. What is a crossover design? So crossover design, in some sense of experimental design, you want to study the medication, and you know that if you use this medication in different participants, the outcome or the feeling of different participants probably different. So in some studies, you want to study at the same population. That's called crossover design. So you study the first medication first for maybe 4 weeks, and then after some time of watch out, you're giving them the same participant the second medication. If you have 3 medication, then you switching to the third medication. This benefit because it's reduced the numbers of participants in the study. But the drawback is that it will study for a long period of time. You probably have a dropout period, a dropout population. And another drawback of crossover design is that the first medication can have a carryover effect. The first medication can have the effect on the second outcome. So that's a drawback of this design, but think about the benefit, like you can study the effect of biochemical measurement on the same subject. And cluster design, you study as a huge group, go together like a community cluster design. Like you study one community, the way that they eat, the day they exercise, comparing to another village, for example. It's called a cluster design. And factorial design that I mentioned to you before, that you can combine medication A alone, medication B alone, and combine between A and B together at the fourth group. And sometimes you see that superiority design, equivalent design, and non-inferiority design. This is, in this case, we compare between medication. You want to see new medication, it's far better than the previous medication or worsen than previous medication. So again, we talk about RCT trial. It's like tossing a coin. So there's many ways that you can do a randomization. You can do sequential randomization. You can do like just a simple like toss a coin randomization. Please go back and look online about the ways that you can do randomization. And this is in detail crossover design. So subject receive a sequential different treatment from active treatment first, and then you go to placebo control, or someone may start from placebo control first and go to active treatments. So this is the way that you can do a randomization that someone may go into placebo test first and someone go to active first. And this helps to reduce confounding factor that can happen between subjects, and it uses fewer subjects, but it has some limitation because, like for example, when we do the cholesterol diet, when you lose weight, you lose cholesterol before, you cannot go back to the beginning that you have high cholesterol because it's already improved, at the second time. So crossover design has some limitation in that sense. And this factorial design, in this example, we're talking about caffeine and alcohol and improvement of the outcome. That's called factorial design. You combine caffeine and alcohol together, or no alcohol, no caffeine at all. And this superior designs. So this medication, this trial is better than another trial, or equal to another trial, or non-inferiority comparing to another trial. Some medication, they produce medication because it's cheaper than the original medication. So you want to see if the effects of the outcome is the same. Like for example. Next, we talk about randomization process. There's a lot of terminologies that you can use and apply to your research protocol, starting with simple randomization, restricted randomization, stratified randomization, adaptive randomization, and cluster randomization. So I would like you to go further and study about this terminology online. And another thing to reduce the bias is called allocation concealment. So allocation, what is the allocation concealment? It's something blind the knowledge of the next assignment to the study participant or staff to prevent the something that they may know before, they have a knowledge before. Let me give you example. Many years ago, we studied the carbohydrate diet. We studied resistant carbohydrate. The thing is that when you give participant a resistant carbohydrate, the diet by itself can cause you a stomach discomfort because it cannot digest by the stomach, right? So when you give a high dose of resistant carbohydrate, some of the participants, they know because they feel stomach discomfort. They feel the stomach discomfort. This causes them to know that they are in the interventional group. Or someone, if you met with researcher, this guy, you know that this guy only do the experimental, not a control study, then they can has a bias on the outcome. Like if you like this researcher, you probably, when they ask something, you probably say yes to this researcher, for example. So allocation concealments can have sequential so that researcher and participants do not know each other before, or the intervention using the low dose to prevent the symptoms that can experience by the participants. Sometimes the blind is not always possible in surgical trial. It's, for example, if you want to do a new surgical techniques to get a better surgical wound or scar outcome, and you cannot do nothing except do a surgical experiment, right? So sometimes you need to accept limitation that you cannot blind everything. You cannot blind device that you use with patient. You cannot blind behavioral intervention, like you want them to exercise. You cannot blind the exercise from them. And like I said before, sometimes you need to do a sham procedure. If you want to study the surgical techniques, you need to do another surgical that we call sham procedure as well, so that it can simulate the anesthetic agent you use or any kind of painkiller medication you use as same as the experimental group. And if you can conceal the bias is called concealed randomization. If you cannot conceal it, you call it unconcealed randomization. And last but not least, people have an experience before that if you have a dropout rate, a high dropout rate, it can have an effect on the bias. So when you do a trial, generally we talk about not to be sample size drop out more than 20%. Let's go into the details. Why 20% come in this equation? Another thing that we talk about is a maximize adherence and follow-up, and terminology we call attrition bias. I think many of you have seen before that in general we don't want participants to drop out more than 20%. And 20% dropouts meaning that you have a problem in terms of content participant in your study. You have a problem in terms of happiness of participant or in terms of complication of the treatment. Therefore, maximize adherence and follow-up is also important in terms of reduce the bias of the results analysis. This is just a numbers that I like to give you the example. Let's say that we have a subject in your study. You have 1,000 subjects. You want to compare between the treatment A and the treatment B. So let's say that after you run for some time, like 1 month or 2 month trial of the treatment, in the treatment A group, it's about 100 people lost from the follow-up. They drop out from the studies. So then you have 400 participants left in your analysis. And from the treatment A, you're showing that 100 participants still have a disease, and 300 participants get recovered from the disease. They get cured from the disease. As compared to treatment B on the right side, they're also losing about 100 participants as well, unluckily. And so finally they has 400 participants left in the studies of the treatment B. And the results showing that the treatment B, about 200 participants still have a disease. And another half of them, they get recovered from the disease. What you see from these results? Okay, what you see from these results? It's tell us that in that sense, treatment A get more recover, because if you can calculate 20% still have a disease, meaning that 75% get recover. On the right side, they're 50-50, meaning that it slightly worked, half of them didn't work. So if you final the research, you probably want to conclude that treatment A is slightly better than treatment B, right? But if you consider the loss of the follow-up in each group, let's say that you can call them back. Let's say that 100 participants from group A you can call back, and 100 participants from the group B you can call them back, and you add more results in the extremely analysis. And I want to mock the result out that if we call them back, and the final assumption and the outcome is that in the 100% that you call back in the group A, is show that 100% they lost because they get sickness and they don't want to go into research anymore. So the final outcome would be 40% has a disease and 300 have no disease, the same, right? But on the other hand, on the treatment B, they lost follow-up, but the all 100 participants that lost, they can get cured from the disease, right? But they just lost. The outcome of both results probably the same, like 200 the same. So meaning that this is just another example that if you lose 20% of participants or animal or cells, it will affect in different way of the outcome. So then in general assessment is that we are not quite accept if you lose participant more than 20% in the trial. Please go back and review these slides and do more calculation. You will understand in this slide that I want to show you. And last but not least, we're talking about something you have to think about when you do research. Also, another factors can affect the outcome, like maturation, pre-testing, system difference, interaction of factors. Let me go into details. So, for maturation, sometimes the participants or the subjects or animal in your studies and the outcome affected by maturation. For example, if you want to study the growth and development in young generation, in young children, for sure, then the age of the kids can affect your outcome. So sometimes in maturation, you have to think about it. You can't study for a long period of time because it can distort your outcome or results, both in young generation and in older generation. And pre-testing, the effects that can create on the second measurements. For example, if you give the questionnaires to participants before and you repeat the questionnaire result after the teaching or after the test, then mostly the second measurement usually is much better than the first measurement. So pre-test can affect the post-test outcome. But if it's acceptable, then this should be fine. But if you want to test the pure outcome, then maybe you don't want to give the participant the pre-testing. System difference, like give you example. When I did a study many years ago, I changed the room of the experiment. Everything else in the room, in both rooms, are the same. Everything else the same. I just changed the room because they are flooding from the water outlet on the top of the room. So I changed the room. But unfortunately, I can't explain why the outcome when I change the room is different. It can happen. So I asked my boss, and she's saying that maybe changing the room affects the lights, affects the temperature inside of the room, affect anything that you probably don't know. So think about it. Change the room, change the climate, change the season of experiment can affect the outcome. Anything can have the effect on the outcome. So you probably want to stick to the same protocol, stick to the same measurement, stick to the same standard test from this company, not changing to different company, And sometimes you can affect by the observer. You have observer and your performance on research probably different. Like for example, solution. So you do a standard method. You try not to change anything during the period of your experiment. Sometimes when you do an experiment and you combine many of factors in your experiment, like you combine diet, exercise, you combine medication at the same time. These effects can have overall effect on the outcome. It's good though, right? But if you want to see what is the major effect on your outcome, maybe it's very difficult to consider about it. So think about it and minimize the comparison to few factors as possible. And like I said before, external validities. This is a problem of us like a researcher. You want to do something ideal in your closed space, in your ideal situation. You do want to do something in very best ideal situation in surgical procedure. Use the best researcher ever. But when you apply it, like you want to apply in general population, in rural area, apply it in far-reaching area, it fails to see the outcome. That's called the failed external validity. So when you think about your research, you need to think about how you can generalize the research to general population. And this is something, the issue that the grantors think about it, that if it's very ideal situation until you cannot apply to make use in human, then it would, the researcher and the grantor will think about it to grant your research funding. So finally, I want you to go back and review before you do a test that today I'm talking about experimental study design that has both observational designs and has experimental designs. Sometimes you can combine between observational design. You do like a cohort design before, and you can select some group of the cohort to do experimental designs. So many times you can combine many designs at the same time. But it can make you difficult to finish your experiment. That is the considered, you have to think about it. And there's many factors you have to think before you carrying out experimental studies. And think about minimize your research bias using randomization, allocation concealment, attrition bias, and other small factors that can happen and affect your outcome. Thank you very much.